big thing about what we do is it's really not discussed in lots of groups or a lot of women. If you're here and discussing it, that's great, because it's such an important thing to be aware of these conditions. So most of the patients I treat have already gone through menopause or are going through it. I'm going to be that young doctor probably until I retire, because a lot of my patients are in their 70s, 80s, 90s, and that's just how it is. But just as a brief intro to what I do, and I'll start with a bit of this and then I'll lead into what Ashley's doing. So urogynecology is a medical specialty that's a fellowship-trained specialty of both OBGYN and urology. You can kind of go in either of those pathways. What it treats are pelvic floor disorders, which most people have either never heard of until they have one, or their family member has one, or you go through medical school and training and get this sort of thing. But basically, if you think about your pelvic floor are all the muscles that hold everything in. So you have your bones here in the pelvis, which she has here, and there's almost this basket of muscles that holds everything in. It shouldn't be too tight, because then it doesn't work. Too relaxed, it doesn't work, but you have to pee and poop and have babies and sex and all these sorts of things through it, and it's not an intuitive thing to control. So as soon as those things start not working as well, which is a little more common after you get through menopause and with age, then that's where I come in to do and treat these conditions. Just a little bit about me. So I'm not originally from here, from Southern California, but have a lot of roots in Northern Nevada, the Tahoe area. Went to Berkeley for undergrad, medical school in Ireland. And everyone can actually read this, I know it's tiny. Did my OBGYN residency at Mount Sinai in New York City, and then a fellowship in urogynecology at Emory in Atlanta before moving here. Oh, and also I go to Bangarang next door, so that's how I got listed into this.
How did you end up here?
Well, I saw her flyers and like, oh, I always wanted more people to know about these things, and just again, it's a big component that isn't usually always part of the conversations that we have around this. So just to be aware of what's there. Again, hopefully you don't need to see me again, which is important. So I was in this region. There were some specialists working, but I'm the first specifically trained urogynecologist who went through the additional fellowship training and research and surgical training here in Northern Nevada. And I brought in Dr. Dowd, who's my partner as well. And we've also worked together here at UNR, and we're actually starting our first OBGYN residency training program, which just got approved 2 weeks ago. So that's going to be starting in the next few years as well. So I work mostly technically through UNR as faculty there, but with Renown, it's a joint group, and we're really building up that group for services for the region. So what do I do? A lot of what I do is surgery. That's fixing the structural problem, but there's a lot of functional things I do in the office, so consultations, getting people hooked in with physical therapy, which is really important, medical treatments, procedural treatments. I also do a lot of teaching of medical students and soon-to-be residents, and then a lot of that we're building research to try to learn more about this, because historically, research into women's health has been poor, and not much of it, and poorly funded, and we're really starting to build some momentum and trying to keep the momentum right now, but trying to build some more to learn things that we need to get better treatment. So today, just understand how menopause relates to these pelvic floor problems, including how the genitourinary, the pelvic area responds to low estrogen, how it affects the bladder, bowel, support, and then when to seek care. Has anyone heard about this field before, or is this the first? What? So it depends on who you know. So what are the disorders that we treat? So something called prolapse. It's never a pleasant thing to talk about, but it's a hernia of the pelvic organ. So the vagina is a natural opening, and you add childbirth and age and gravity to it, and things can fall out, and they do in about 1/5 of women, actually. Wow. And so one of the main surgical things I treat is trying to put things back where they're supposed to be. Yeah.
Is that more common in people who've had more children, or does it really matter?
More kids is correlated with more likelihood of having a problem, but it depends on kind of what's damaged at that time. Some women, there's some genetics involved too about how stretchy your tissues are. But it could just be one really bad injury that's thrown off the structures, or more birth that's led to it. It can still happen even if you haven't had kids, it's just a lot less common. So there's a lot of pressure down there. But no, kids are great. They cause some damage. It doesn't just, it's not like the nature videos and other animals where it just it takes a lot of work. So it also affects, again, things people don't want to talk about. Urinary leaks, bowel leaks, difficulty emptying. Rare stuff I treat, there's actually just did a surgery 2 days ago where holes can form between different organs after surgery, or cancer treatments or things like that. injuries that childbirth happens like immediately afterwards, they can hurt the sphincter. Structural issues, less common things here: bladder pain, recurrent bladder infections, sexual problems, and all those that go together. So this is where I spend most of my time. So menopause, that's why we're here, right? Or menopause? I like that name, by the way. So I know you're getting other talks that are specifically focused on like hormones and menopause. I'm not going to go into too much detail, but just to give I'm very particular about people getting the most current and accurate information. I want to at least give my plug on that sort of things too. So menopause officially occurs when you stop having periods for a year. It's tricky when you've had a hysterectomy or something like that. But there's a big transition period until that happens. And it's because the ovaries, which by the way, if you were born 100 years ago, everyone kind of died by 50, right? So that's why their body wasn't really designed to keep making that reproductive potential after age 50. So that's why that's still the average age we see it, around 51. But the ovaries stop ovulating, and then the hormone feedback starts to shut down, and then you start having this bumpy pathway of perimenopause with the estrogen levels, and then it just kind of slowly bottoms out over time. But your body, for women, is designed to be stimulated by estrogen. It functions the best. That's why you have better heart health and bone health and all these things compared to men until you go through menopause, and then you catch up with our heart health and bone health because we don't have that. But yeah, average age between 45 and 55, and perimenopause can start as early as 35 with those changes that happen. And then just my quick plug for hormone replacement therapy, because that's not the focus today. Just the one thing, it's so safe for nearly everybody. There's always some problems with people where it's not the safest, we don't know enough about it yet. There's a whole, actually some of you, there was a whole generation that kind of missed out on this, because there's this evidence that came out that people were scared of getting breast cancer and clots. We're understanding it a lot better. We have cleaner hormones, or ones that are more identical to what's circulating throughout your body. And really, when you look at it now, estrogen almost makes everything better. We're seeing that it might prevent breast cancer. That it protects your heart, it helps your bone health, it helps your overall, then other stuff, skin, sleep, mood, sexual function, all of these things. So when you're looking for someone to treat that, which we're trying to build up resources, there's not that many people doing hormone management in the whole country, but especially this region, it can be hard to find, and there's long wait lists. Just make sure they ask if they adhere to the most evidence-based care or the OBGYN recommendations that are based off what we know. We don't recommend really regular hormone testing every 3 months, or just checking on that, because really we're trying to get you to feel better, and that's the key. That's all the estrogen you need. It's like a teeny little dose that brings it up. But like balancing hormones and things like that, there is some benefit in certain patients, but a lot of the time it's just more money, more visits, and it doesn't really make as big of a difference. So we just want to make people feel better without extra costs. And if you're getting hormone replacement with estrogen, transdermal, meaning through the skin, so it's either a patch or gel, is always overwhelmingly the safest compared to a pill. Some people might prefer the pellets, which you have them less frequently, but they're harder to control, so they're not our favorite, but there's something that can be managed too. So that's just my plug of, if you're gonna just ask, are you following these guidelines? What kind of testing do I need? And really you're just trying to get that lowest through the skin dose possible to make you feel better.
If you missed your window, like for 10 years, and then you start it, it's still protected.
Yeah, so we know the best time to get all the benefit is to start probably in just the beginning of menopause up till age 65.
But if you're 60,
But over 60 or 65, there's still probably some benefit there,
Okay.
just not as like
'cause I
barn
had
door,
10
and it's
years-
also probably very safe. Yeah.
Okay, so 58, it was 10 years out, and I got up, now I'm 2 years in,
Yeah.
estrogen, but.
We're not asking anyone's ages here, Beth.
No, but I mean, I'm sorry, I'm just.
No, no, it's fine.
But I mean,
There's no window.
benefit to stay on.
Yeah, if you're see me, I'd say there's really now no window where you like, I won't start it. It used to be also like, you must stop by age 65, or you like
Yeah,
miss this
that's my
opportunity. Now
question.
there's actually, it's pretty safe to continue past that. If it's helping your symptoms, it's nice to try to come off it if it's not really helping you too much, but if you're still feeling great on it, then continue it unless there's major risk factors for it, as long as you're doing the safest dosing out there, the lowest dosing that you need. The big things we're scared of, if you have like recurrent blood clots, true estrogen sensitive breast cancer, it's one of those where actually it's probably safe, but it's still a tricky one where we still want to know a lot more before we get
Yeah.
someone a recurrent cancer or something like that. liver problems, heavy smoking. Those are just the things we don't like to start it in. But I've started in a 70-year-old last week, and we'll see if it works. If it doesn't do much, then we're like, okay, it's not doing much, so we're gonna stop and see. So that's my plug. This could be a whole lecture for me too. I know you're getting stuff. Yeah.
Blood testing or no? That is kind of, it doesn't really matter.
Like our society kind of doesn't, it doesn't recommend it
Yeah.
because it hasn't shown to give any benefit or
Okay.
improvement. Now, sometimes people are looking if there's very specific symptoms, and we're learning more, mostly around either like sometimes sexual function of like, do I need to throw some testosterone in? There can be some benefit for some women of testosterone for like lack of desire to bring it up, but you have to be very careful with it to get the right doses there. So you have to trend that for just general like estrogen, progesterone, really, because there is no number that correlates with feeling better, and there's no number that correlates with long-term outcomes. It's just trying to get just a little, just enough to make you feel better.
Okay.
And this is teeny. This is way different than birth control doses. Those are much higher doses, more synthetic. And the term people like is bioidentical as well. I put it in quotes because it's not really a medical word, but it just means the same circulating stuff that you have, rather than older estrogens, which were animal-derived or things like that. But they're all synthetic usually. And actually the synthetic ones that are circulating are actually considered the safest. So
Thank you.
yeah, there's just a lot of buzzwords around it.
Yeah.
And actually the pendulum swung the opposite direction now, where now I say take caution because estrogen is great, but it's not the cure for everything. So now it's been like, now this FDA warning has come off, estrogen fixes everything. That's not actually the case.
Yeah.
It fixes a lot of stuff.
There's
It's
a
great.
lot
I
of-
love it. But now it's
There's a lot
not.
of people doing this.
So that's why it's trying to find the best, safest people. That's just my speed. I see some people just coming in. I'm like, what's going on with these hormones? So you want to do it, we want to do it well. So back to the pelvis. Then. So there's something called genitourinary syndrome of menopause. It just means the effects that menopause has on pelvic symptoms. It's interesting, some women, I see someone who's 90 and has none of these symptoms, and some women as early as 40 start having these. So some bodies are just more sensitive to it than others. But when I'm doing an exam and looking, everyone shows physical changes of this. Like there's thinning of the tissue, and that could affect pain and sensitivity, bladder function, bowel function, and things like that. So this atrophy is not a very fun sounding word, but basically you take this nice thick tissue and it just gets much, much thinner. So some people feel dryness and itching and burning, pain with sex, and this is like the cure. Safe, easy stuff is getting some estrogen back there. But it also correlates with overactive bladder, so having to go too often, recurrent bladder infections, bladder pain, vagina can narrow and shorten just because of the lack of stimulation down there, because the tissue is supposed to respond to that hormone and now it's gone. The nice thing is this is very fixable. So when we were talking about hormones before, that was systemic hormones. That's like patch pill, that kind of stuff, the whole body. Vaginal estrogen. Sorry, I say vagina a lot. Vaginal estrogen
We all have
is, I know one doesn't, is still estrogen replacement, but it's a whole different thing. It's topical. It's not absorbed into the bloodstream. So even if you're not someone who's safe for other estrogens, this is safe in truly everybody. It's magic stuff. So basically it reverses those changes in the vaginal tissue and in the bladder over time. The annoying part about it is you have to put it inside. There's not like, you have to topically place it, and there's creams and pills and rings that you can do that with different coverage from insurance, just twice a week, but you're just trying to get that tissue to rebuild. And I have some people where that's all you need, just fixes everything. Or other people where I want to get their tissue healthier just for other things that we need to do. But again, no, we give it active breast cancer patients, people who've had strokes. There's truly no one who can't have it. So if you do have these issues and someone says you can't, just come see one of us and we'll get you some of this treatment because it's very helpful. So there's also non-hormonal treatments, and this is an older slide because really recently all the data showed how safe it is. Even before, like maybe in breast cancer we shouldn't give it, maybe in some of these other people, but now we know it's safe. There's obviously lubricants, there's vaginal moisturizers, which just make it less dry. It doesn't really fix the actual other problems. There's laser therapy, which there are a lot of practices that offer that here, and it can work pretty well, but usually not durably, and estrogen just looks better. And there's a medication that is almost never paid for by insurance, but there's a pill you can take that makes the tissue better. It's safe, it works well, but it's just really hard to get. And actually stopping smoking can help with this as well. we're actually going to go over lube a bit because there's actually a lot of science behind it that people don't understand. There's a ton of products on the market, and it can be confusing to what to use. There's a difference between a lubricant and a moisturizer. And if you use these and you have no problem, it doesn't matter what you use. Don't overthink it. But some people are really sensitive to certain ones, so it's nice to know what you can use and can't. So lubricants are lubricants. It's when you need them. So sex or anything else where you want things to be more slippery. And then moisturizers are used regularly to keep things feeling better over longer periods of time when you have a lot of dryness and irritation symptoms. So when you're seeing those different products, that's what it means. So like more of a moisture barrier means less discomfort. They're not all built the same. And actually some colleagues of mine did a huge, interesting research study on the science behind it. And that gel, lube, actually has these properties where it can actually really draw a ton of moisture out of the tissues in certain people. And some people don't notice that, but some are really sensitive to it. So most of the cheap stuff or the affordable stuff out there, like KY and Astroglide, things like that, can be really irritating to some people. It just draws all this moisture in the wrong direction, and people don't like that. There's some that are much more better formulated for it. So I can always send these slides out as well. The most scientifically backed one has a fun name. It's called exclamation point, yes. They make a lubricant and a moisturizer. Silicone-based lubricants, unless you have recurrent infections, are great because they don't have any of that impact on the tissue. KY is fine as long as it doesn't bother you. It's cheaper than all the other things, but this is just people. There's so many products out there. It's nice to know kind of where the actual evidence is behind it. So talking about morning on Saturday, and there's a whole chart here that goes through it. You can't beat that. Any questions on that stuff so far? No? Helpful, hopefully. All right, let's talk about the bladder, which is really where I come in. So, bladder infections. Can I ask who's had a bladder infection in their life at least once? They're really, at least, 2/3 of women get at least one in their lifetime, but especially after 50, they become much more common. And it's purely because the tissue, as we talked about, thins. The pH, so the natural environment there, changes as well. So it's much more, it's much happier for bacteria to grow there. So usually the bacteria from the gut, so from your stool, even if you're really clean, they're in this similar spot, sticks to the end of the urethra and then just keeps causing infections over and over again.
So,
Yeah.
question.
Yeah.
Is a bladder infection the same thing as a UTI?
Yes. There's different versions. There's like severe bladder infections and UTI, bladder infection. I like UTIs. Sometimes I say UTI, people are like, is that the same as bladder?
Yeah, well, I was.
So
assuming-
bacteria in the bladder that cause burning when you pee, pain right here above the
Gotcha.
pubic bone, urgency, frequency, like going all the time, or difficulty emptying your bladder are the common symptoms. Actually, after menopause, it's more subtle. It's usually more having to go more often and leaking more often than the pain symptoms.
How do older people get those and not really?
And that's a tough.
I don't. If I'm
It's true.
taking
No, yeah.
you in a different direction, we can.
Is this? Yeah. No. It's actually
Just the-
written papers about this. So it's harder because there's a difference between having one and not knowing you have it versus if you don't have symptoms, you actually don't consider it an infection. Some people are just colonized with bacteria that just sit there. We've actually found that we should leave it alone for most people.
What
But that's
about
when you have an
people that
older
go
person with
crazy?
dementia and things like that. It's really hard to decide when to treat UTIs. And actually, I just gave a talk at the Family Medicine Conference in Tahoe about how hard it is to differentiate between those two things. And we're trying to learn more, but sometimes you just don't know for sure, and that's hard. But for when we have all our faculties and are able to sense it, it is a bit more subtle when you get older. But usually, if you don't have any symptoms in the bladder area, I don't really care if it's growing there. We just let it do its thing. Because you actually just be calling it. The urine's not sterile like we used to think it was. There are bacteria there. It's just how much. And certain bacteria cause problems and others don't. So you kind of have to figure that out. And I see a lot of infections in my practice just because it's such a common thing. But yeah, basically it just means bacteria like to grow more when you have a not as hospitable vaginal tissue, because that's where the urethra is. And women have short urethras, there's no prostate there, or varying lengths of urethra that men have that kind of block things from moving up. So if you have more than 2 UTIs a year, it's recommended to see a urogyn, and generally the treatment is vaginal estrogen. The same thing I talked about. You go on that, is the #1 thing that prevents it from coming back. it's safe, it reduces infections incredibly, it reduces symptoms that feel like UTI that aren't. And then there's all these other more advanced treatments if we need to. But some women get like 10 to 12 a year. That's terrible. That really impacts your quality of life, and it damages the bladder, it hurts. That's just this whole cascade. So with this group, the thing is to always get ahead of it. If we start in that pathway, like let's get it managed before it turns into a much more chronic stage. But also, besides infections, there's overactive bladder, which is going either too often, like 10, 15 times a day, or having the urge to go to the bathroom and not making it in time. We call that urge incontinence, where you just don't have that morning time anymore, and you have leaks. Waking up at night more to pee, difficulty emptying the bladder, and there's a bladder pain syndrome that feels like bladder infections, but isn't. It's just a damaged bladder that hurts. Which is really good to treat. So it seems pretty obvious that urinary incontinence is when you leak urine. It's a simple definition. People want to keep pee inside their body rather than outside. It's really common, more in women than men, again, because women have shorter urethras plus childbirth injury, right? So it just makes it more likely for that structure to get damaged. Although men can get it too, especially if their prostate comes out, then all bets are off for men incontinence as well. It's more likely as you're older and those that are in nursing facilities as well. And it's a really expensive thing to treat.
Do you have less or more damage from having children cesarean?
Less, usually. But it's tricky because there's still the pressure of pregnancy,
Yeah.
which can cause some nerve damage. Not every C-section is a planned one, actually. Many of them aren't. So you already labor it, and then you have a C-section. So you get the double whammy of the pelvic damage and still having the C-section.
Okay.
But I always say most women I see for certain conditions, not incontinence as much, this is has less relation to childbirth, but like prolapse. If they haven't had any kids or had one C-section, like, is it actually that? Because it's not as common to see it, but we still can. You probably can't read this, it's too small. But there is a huge impact on stigma and quality of life with this condition. And these are just patient testimonials about how much it affects quality of life. I teach this to medical students to ask them to screen in any other specialty just to refer to get care, because a lot of women don't seek treatment or know that there's treatment, and you don't have to live with the problem. So, what I say is, it's common. We don't consider incontinence a normal part of aging, meaning it's something you just have to live with, right? Now, I can't get everyone perfect, but there's a lot of things that we can do to get the quality of life better. Incontinence can impact physical activity, social activity, coming to the gym. That's what I hear a lot is, jumping, lifting. What?
Jumping rope?
Yeah, jumping rope at the gym is a big one. Also, now it's so popular at trampoline parks. That's like the biggest
know.
thing
Yeah.
people
I can get you there if you want.
Yeah.
No, I'm out.
It affects work, it affects sleep. If it gets really bad, then there's infections and sores and all sorts of things that we're trying to prevent people from getting to. So I kind of skip to this. Yeah, not normal that you have to deal with. 1 in 3 women with incontinence don't seek care. So this is why I like to do these talks, is just to be like, hey, if this happens, there's treatments for it. And a quarter of women didn't think of this as a health problem that needed to be addressed. So that's the gap I'm trying to close.
Yeah.
So what causes it? And the answer is it's really complicated. It's not just the bladder itself, although that's what I usually focus on, but if you have heart conditions, that relates to it. Diabetes, nerve problems, back issues, hip problems. What, sorry?
Sleep apnea?
Sleep apnea is actually really hidden, what people don't know. If you're waking up at night all the time and having to pee, it's actually because you're probably not breathing as well. You're making more pee and you feel like you need to leave, but really have sleep apnea that needs to be treated. But a lot of this is functional, which is the nerves and muscles of the bladder. And again, that age and menopause related. Aging, it's not the fun for anybody, but it's better than the opposite. So there's a few different types of urinary incontinence, which I'm simplifying, but if you're going to seek care for this, it's really important that this is reviewed, because when I see problems with how this is treated, it's usually the wrong treatment was chosen, or the wrong type of incontinence was treated, or it's the wrong patient. So it's really important when I see people, I'm really trying to hone in on exactly what's going on, because if you don't do the right thing, you can make things worse. So, has anyone heard of these before, like stress incontinence or urge incontinence? So stress incontinence is the jump rope one, right? It's physical stress, so jumping, laughing, coughing. No, you're supposed to do jump rope. Double unders, all this
It's
stuff.
good for you.
Yeah, it's very
Good for your bone density.
Exactly, yeah. Weight bearing exercise is important. So also like sometimes it's intercourse or coughing, laughing, jumping, all these sorts of things. But it's because again the urethra is short, it's not held up as well as it should be, and then just the pressure overcomes that tube's ability to hold things in. So think of it as like leaky plumbing. Right? Urge incontinence, which is the same as that overactive bladder, is that gotta go, run to the bathroom, can't hold it, don't make it. And that's actually a problem with the bladder muscle itself. It's squeezing before you're ready for it. Your bladder should fill and then start sending signals to your brain saying, hey, maybe you should get to the bathroom. But you're like, no, I'm at Trader Joe's, I'm just gonna have to hold it. I can wait till I get, or I tried to fit in skiing this morning, I'm like, I can make it before I change and come to this thing, that sort of warning sign. But some women, that warning doesn't matter, your bladder squeezes before you're ready, and then you're fighting your bladder to get to the bathroom. And with something called mixed incontinence, which is most of people I see as a mixture of the two, so it's really uncommon to see just one or the other. There's usually some mixture, but usually something's winning. I kind of just went over this, I'm used to talking about it. But again, stress incontinence is a structural problem. That's why I usually treat it after physical therapy with surgeries or small procedures, because you're trying to make the exit stronger. There's not a pill that does that, unfortunately. And urge incontinence is a nerve and muscle problem. So you're trying to get the full system to work better. So that's where we have medications and nerve treatments and Botox and all these other things that can go Botox, right? Yeah. Overflow I talk separately. This is really less common for women unless you're much older or have had surgeries. This is where men's problems come in because their prostate blocks everything off. Basically, your bladder can't empty either because it's too weak or it's blocked. It gets so full that it just overflows and pee comes out. So this is trickier to fix. But in women, it's usually they've had a procedure that blocks something, or sometimes age-related or nerve-related. The bladder just stops squeezing anymore, which is kind of just a bummer. There's not a good fix for that, but it's something that we're looking to see. This is a bit more complex, but this is how complex all the nerves or the muscles I'm going to show it are in the pelvis. Interesting. So when you think of a valve, like in a tank or something, or a sink, there's nothing actually shutting off the exit to your bladder. It's just a tube that's just hanging out there. Not this thing. There's no sphincter. So what actually the muscles of the pelvis are holding up the vagina. And the vagina is the shelf that the urethra is sitting on so that it stays in a good position inside the pelvis. If any of that falls away, this can suddenly start flopping around, and that's why pee comes out. So that's when we talk about the treatments, we're trying to get that support back under the urethra, or just injecting it to make it stronger. So basically it's just, it's the tube's not seeing into the pressures as well. It's more of a sciencey picture, but if you think of your belly like a big, tank, all the pressures when you push and cough should squeeze this closed so it stays closed. And as soon as you fall out of that protection, all bets are off. That's the cough, sneeze, laugh, jump rope. So what to expect if you see someone like me? Because also a lot of people put off doing this because they're like, I don't know what kind of exams they're going to be. Again, there's this 40-year-old dude with glasses. I don't want him to do a public exam on me, all these other sorts of things. So what can you expect? Detailed questions. You go into extreme detail about how often do you have these bladder problems? Like, how severe are they? What brings them on? You're trying to get an idea of it. Usually do a little scan to see how well you empty your bladder to make sure that's not involved. Usually test your urine to make sure there's no blood or things like bladder cancer, things like that, or infections. And then sometimes we do this test that isn't the most fun thing, but we do bladder tests to really see what's going on if it's not clear. Because as we said, if I choose the wrong treatment, I cause problems. Not to scare people away, but there is a bladder test that some women need to have. So you sit in a cool little toilet chair with a really nice nurse in our room. Basically, we're filling your bladder till it's full to see why it's leaking, and then we actually try to provoke it to see what's going on so we can figure it out. But not everyone needs this. This isn't the first visit. It's something that we talk to you about. And she doesn't look very happy here, so this is but we do have to test sometimes to make sure we do things. So what can we do about it? So there's a lot of behavioral options, and if you want to jump in at any point, feel free you can. But for water, some people when you're leaking all the time, they cut water out. That makes you make less urine, but when you have that dark concentrated urine, all that does is irritate the bladder more. Actually, you have less control. So water's your best friend. Everything else is good. Everything that's good is not fun for your bladder, unfortunately. So coffee, tea, carbonation, sugar, fake sugar, alcohol, all the good stuff. But if you have a lot of urgency, just kind of find out what your triggers are, and if you can cut them out, it can help. But again, this is about your quality of life, right? Interestingly, cranberry juice doesn't really help UTIs, by the way, and it's a huge bladder irritant. So if you're drinking a lot of it, like, I can say,
What's water? How did it get this route?
now, again, whole other field, but there is a specific part of cranberry that can help a specific type of recurrent bladder infection or UTI. And actually, that is really science-backed, and I prescribe some supplements for some people. You can't drink enough cranberry juice to make it work. Most of the supplements out there don't work, but cranberry juice is just really acidic, and there's a lot of things in there that irritate the gut. So, not dangerous, but it doesn't really do much either. Yeah. And then you want to talk about, I kind of skipped it, but here's Ashley.
Where I jump.
Yeah.
So, first of all, how many of you have heard about pelvic floor physical therapy? Okay, so good majority of you. Okay, so,
Oh, yeah, your
yeah.
slides are at the end.
Okay. No, no worries.
Good job.
So, one thing that we do with pelvic floor physical therapy is a few slides ago he mentioned this like canister, or what I like to call like a piston. So, if we think of the diaphragm is up here, so when we take these deep breaths in, we breathe in, diaphragm comes down, and our pelvic floor muscles should also kind of drop down, so that it manages the pressure inside the canister. And so, back to kind of the stress incontinence, if we cough, sneeze, laugh, jump rope, anything of those types of things, and I tend to see that the abdominal wall is coming out because we have any core weakness from maybe multiple pregnancies or things along those lines, then what can happen is, unfortunately, we are designed with two holes in the bottom of our pelvis. That leads the pressure downwards, and so we need to make sure that your core and your pelvic floor are coordinated together. So if we cough, sneeze, laugh, this fascia or tissue can actually pull up and in. Pelvic floor muscles can follow suit with that, and then that would decrease the leaks that you're having with stress incontinence. And so, you know, with menopause, everyone's talking about, okay, well, you need to weight train. Like, how are we supposed to lift heavy weights if we're having leaks with it? Or how are we supposed to lift heavy weights if we're feeling pressure or prolapse-like symptoms, which we haven't gotten to that yet. But, you know, if we're feeling those symptoms, how are we supposed to increase our bone density with weight training and jumping and all of those things if we're feeling symptomatic or we're having any pain in like our hips or our lower back? Because as estrogen decreases, unfortunately, tissues become stiff. They don't have as much springiness to them. And so we really want to make sure that muscles, joints, all of that are moving well together. And so that's kind of the gist of pelvic floor. PT will get into a little bit more there, but just working as a full system, essentially.
My plug is a lot of people come to me either having tried some conservative things or haven't, but people see the surgeon want quick fix for everything. Not everybody, but a lot of people do. And I'm always trying to emphasize not everything, for many things, pelvic floor physical therapy is my non-negotiable. Because yes, I can make the structure better, I can do injections and all these other things, but if you don't have good functioning pelvic muscles and you don't know how to do that well, the results aren't as good, and then as you continue to age, things keep getting worse, right? So it's like, think of it like an important reset. I'm really trying to sell. There's several groups in town we try to, I'm very careful about who you refer to. The important things is you have to go to a pelvic specialist. There's really great physical therapists in town that do general PT, but unless they're really focused on the pelvis, it's not worth the visits. You should be asking people if they do, which he does, it's internal work, which is going to talk about, which can be surprising. I like to set people up for that. Because just external stuff really isn't sufficient for most people. And what was I going to say for this?
I was gonna say, we can get you there. Like, we can do
Yeah.
external stuff. We can get you there, but you might not be 100%. It might be we got you 60% better, maybe 70, or it's like we're just not even using the muscles how they should be. So it's important that we have that internal aspect of it to really see what those muscles are doing, what the tissue feels like, is it responding. A lot of the times, you know, I'll ask people to do a Kegel, and this is what's happening. we're using our glutes, and we'll get into, you know, I think it's also not always about Kegels. Sometimes we actually need to learn how to relax the pelvic floor muscles and use them through their full range of motion so that they can be springy.
I'm also all for it. Everyone, because sometimes it's busy or accessible or insurance coverage is hard. This is one of those things that really the results aren't there for self-guided stuff, or even there's really well-intentioned online stuff. It's hard because a lot of the things, and I see this all the time with patients and you too,
Yeah.
it's really not intuitive how to muscles. And you think you're doing it right. And actually, one of my colleagues, Dr. Dow, who I'll put on here, she just gave birth, so she's off right now. But she was doing her pre-PT, and she's like, I thought I was using my muscles correctly, and I wasn't. I'm a urogynecologist. I should know these things, right? So you really need to be guided on how to do that. It's not like your biceps, right? It's a very different kind of pelvic structure.
Yeah.
So that's why, unfortunately, it's not just to go online and do Kegels. It just doesn't work very well.
Or the joke that women always have.
So?
Kegels.
I mean, they don't hurt. You know?
Yeah.
Like I tried to New York, everyone's like, you can do them on the subway. No,
Yeah.
no.
Right.
But you have to make sure you're doing it for the right reasons.
Do you have a question?
Yeah.
Yeah.
You talk about the way the body works. So, for example, you're sitting on a plane, you can't get up, there's turbulence, and all of a sudden, like, you gotta pee really bad to get off, but then your body's like, screw you, it's frozen, and you can't. Can you explain what your body's doing? It's like opposite.
Like the hesitancy of like,
your bladder won't release, and so you're sitting there in pain, your bladder's too full, and it's like too tight and won't relax. Can
Right.
you explain what's going
so,
on?
you get that really strong intention urge. So your bladder here has stretch receptors in it. And so as things are starting to fill, your bladder is starting to stretch, and then it starts to send you those signals. Might get a few of them, and it's like, okay, maybe you should get there. Then it's a stronger sensation, and then you get that really, really strong urge. Well, how our pelvic floor muscles react to that is, well, shoot, we don't want to have a leak, right? So then they contract. So they tense up. So we're sitting here on the plane doing the potty dance, holding in our muscles, and then we finally, we get off the plane, or we, ask the person next to us, hey, can you move so I can use the restroom? And then we sit onto the toilet, and our muscles are so tense that then we're like, okay, we're sitting here, we're really trying to get them to release, and they're not doing what they need to because they've been holding in that pattern. And so then we have to teach the muscles, okay, maybe we need to do some breathing strategies, taking some deep breaths in, helping the nervous system also kind of down regulate after, oh my gosh, I might have a leak on this plane. Can we get those muscles to release down? And then it sends a signal up to the bladder, or up to the brain, down to the bladder, and the bladder's like, oh yeah, okay, we're good. We can release now.
And while it's common, it's one of those things where while it's common, it's actually not how they should be working. So if you're having this, right, I really have to go, and then suddenly you can't, it means there's some sort of misfiring that's happening there. And again, it's not usually anything scary like a cancer or tumor or things like that, but it takes just some relearning how to do it. That's actually where the Kegels work against us. Strengthening doesn't help when you can't relax your muscles. You actually need to
Yes.
learn. Actually, a lot of this is learning how to relax, which is completely counterintuitive. How to breathe. And like some of the first visits, you have just how to breathe, and you're like, really, this is physical.
Yeah.
But no, it's one of the
A
more
lot of
important
breathing.
things.
Do you do biofeedback too? Is
So,
that part of it?
at our practice, we do not. I've worked in previous practices where I have done it. And when I've used it in the past, a lot of the times it's I'm struggling with other technological issues that I'm like, okay, I could be doing other things with this patient. So can it be helpful? Yes. Are there devices out there, that you can purchase and that you would insert in and things along those lines? Yes. However, when the device is inserted in, it takes your baseline. And I say baseline in quotes because your baseline, you might already be holding tension, and that's going to read as you're relaxed. And so really, our way of biofeedback is doing that internal assessment and seeing, okay, can you actually fully release the muscles? So our biofeedback is we have fingers, okay? We can feel when you actually get those muscles fully relaxed, if they're holding tension. During the internal assessment, a lot of the times we'll move legs into certain positions, we'll do different breathing strategies to help you actually feel those muscles release down. So.
There actually are some pretty promising devices out there. Again, an OBGYN just texted me yesterday about this new device that I'd heard much about it, and I looked into it, and it's probably helpful, but usually with these things, again, I'd say consider it once you have that baseline function, having taught you something. So once you know how you should be functioning, this can help you do things at home, get things better, maintain. But it's complicated. Like, it's one of those things I wish it were simple, but it's not a simple process. So moving on to some other treatments for incontinence. This is my favorite one, but there are some inserts, like these things called pessaries we usually use for other things like prolapse, but it puts a little pressure on the urethra just so it's a little harder to leak. It goes inside the vagina and stays there. There's actually a new device that we're fitting patients with. Again, these are weird names for things. It's called the Yoni Fit. but it's almost like a menstrual cup, or if you've seen diaphragms before, it's like that. But it just kind of sits in the vagina and puts pressure on the urethra. And it's really good for situational leaks. Like I'm going to go have a really good exercise class, and I don't want to leak, so I'll put it in for that, and then you take it out at night. But it's not a fix. It's just trying to make things so your symptoms get better. Again, I'm always going to plug vaginal estrogen. It can actually make your urethra stronger and decrease that urgency too. So magic stuff all around.
Is that a prescription or
It's prescription only. But again, I prescribe it like candy too.
like candy?
Yeah, it's great. Everyone gets it.
It's like
Everyone,
Oprah
like Oprah, everyone gets
Do
estrogen.
you think
right?
the cream
Yeah.
is better than the little tablet, or?
It depends on what we're treating. For milder symptoms, I don't really care. The tablets are less messy, which is kind of nice, as long as they stay in. Some patients, they can't. The cream I just like best because it coats everything. The whole system just works really well, although it's a bit messier. There's rings, they're just really expensive. But yeah, people have really severe symptoms, the cream really works best. And if it's expensive, never trust an expensive medicine, right? Because it's usually the pharmacy benefit and the insurance racking up costs for no reason. So vaginal estrogen baseline egg cost is about $10 for a tube that lasts 3 to 4 months. Some people get charged $300 for their insurance for that. And there's an online pharmacy called Cost Plus Drugs. You can get it for $13 for 3 months. So there's ways that you can get access to this.
That's
So,
with insurance?
and that goes that website like bypasses
Oh,
insurance.
got it.
But yeah, just never trust a really high cost of a med that you don't need to. So other medical therapy, there's medications that treat overactive bladders. This isn't the trampoline one. This is the rush to the bathroom can holder. So there are pills for that. They work okay, not the best. What they're trying to do is take that contracting muscle and just calm it down. There's a lot of ads about it, on TV for all these like dancing bladders and things like that. They just don't work well for everybody, and some actually have some pretty important side effects to know about. So this is my big plug too, is that the most common and cheapest medicine, the class is called anticholinergics, but you might hear oxybutynin or Detrol or tolterodine. They've really been shown that long-term use can have some pretty scary side effects, like increased risk of dementia and memory loss and all of these things. There's some safer ones out there, but really I've moved away from prescribing most of these medicines, except for in certain people or younger people. Over age 65, no one should be on them just because they can have that risk to them. There's a second class called beta agonist, that's Myrbetriq, something called Genteza or Vibegron. They're really safe, but they're still in that expensive category because they're newer. So one of them's come off patent now, but still the price hasn't dropped yet. So these are great, but I have trouble getting coverage for it. And again, they only work in half the people. But there are medicines that work for some people. You have to take it every day for it to work, right? So it's like a forever med. This is not my favorite thing either. There's more ads there. And then this is where people get past, like I've done my physical therapy, I'm on my estrogen, I've tried all these things, I'm still going 20 times a day and I'm leaking on the way to the bathroom. What should we do? This stuff works really well. This is what I do mostly. So there are procedures that are all minimally invasive, but they're trying to make the bladder relax more. And again, this is for that frequency, urgency stuff. So I do a lot of Botox in the office, and it's not to make your bladder look glamorous or anything. But Botox, it can be though. But Botox works in our face because it relaxes the muscles here. It works for migraines, it works for other muscle spasms, so I use it for bladder spasms. It doesn't look very fun. Yes, I have to put a little camera in and poke your bladder with it, but I know those faces. We numb the bladder first. Once the injection takes less than 30 seconds, people tolerate it really well. But this lasts 6 to 12 months, so it's even longer than a lot of the other Botoxes. Really dramatic change in symptoms. So over 80% of women have a dramatic decrease in their leaks. I always do that fun test beforehand to make sure if you have a weak bladder, this isn't a good treatment because it just makes it extra weak, but most people respond to it really well. And then there's these 2 nerve stimulating treatments. So we're trying to reprogram your pelvic nerves to work better so you don't leak and so you empty your bladder better. There's an office procedure. It's almost acupuncture, it's not, but you put a little needle into the ankle where there's a nerve here, and that nerve goes all the way up to the same nerves where your bladder is. Put a little stimulator on it. Has anyone had a TENS unit before, like in PT? It's kind of like that. So you have this little tingling feeling in your foot. You hang out in the office. It's an office procedure, so you hang out in the office for half an hour. It takes a lot of treatments. It's a weekly treatment, but over time, it works better than those medicines, and it's more durable, and just trying to get the bladder to function better. And I love that for the not too severe person. Like I'm going too often, I have occasional leaks, but that's not flooding myself all the time. That's a really good option. And then you actually have pacemakers for your bladder. That's what this one is. And again, it sounds way more intense than it is. It's actually a really safe and minimally invasive procedure. We test it out first. We do a little trial to see if your nerves even respond to it. And if they do, most people are really happy to get that device put in if it works. But basically, it's this little teeny probe that goes near the nerves and kind of through your back here. And it just helps them function better. It's on all the time. You don't have to do much with it. It's safe to go through airports and get MRIs and sorts of things. The nice thing is that helps people empty their bladder better and have less leaks. So these are all the things. Of course, if you can fix it with PT, great. But if a lot of women, it's more complex than that. And that's where I come in. If you're really severe, there's like spine injuries and really bad nerves and muscles, then there's some reconstructive urologists that can rearrange your bladder, but you want to avoid that. They're not very fun surgeries. So for stress incontinence, that is the jump rope one. It's a physical problem. So besides the training and the insert, it's me trying to fix the strength of the exit. So this is where you hear things like slings and bulking injections and that sort of stuff. And these, I also want to just promote how safe and effective they are if done in the right person. So what a sling does, which is here, which is our gold standard, is it takes that urethra where the support's fallen away and it's flopping around, it just puts the hammock back under it so that support's there. It's trying to bring things back inside the pelvis. Mesh. So that's the big thing. People are scared of pelvic mesh, and for good reason. Historically, mesh has been used when other stuff doesn't work. We keep using it because all the non-mesh permanent stuff just fails. So it just still works the best because it lasts forever. There were some prolapse meshes that were put through the vagina that were over-marketed, poorly designed, all this stuff. That's what caused a lot of that late-night TV mesh lawsuit stuff you hear about. Those are off the market, and I fix those things. But slings and a different treatment for prolapse that we have been used for decades very safely. We've studied them intensely to make sure that they're very safe. But it does use mesh, and you can't pretend it's not. There's some risk to it. We see that maybe 1% of people can develop a mesh problem, although it's usually pretty minor, where it can irritate the vaginal tissue and stick out, or it can be either too tight or too loose. But the thing is this, it takes someone who every time you try to exercise or cough or anything, you're peeing your pants to curing it, in 90% of people. So it's my favorite, I call it my favorite high five post-op procedure because it just so dramatically changes things. But again, the key is putting it in the right person well. I can say this more legally now. There have been some people in this region who have been doing some somewhat unethical practices, which has kind of been hard of putting a lot of procedures for people that didn't need them with poor technique, and they've lost their licenses, so it's not something that you can see now anymore. But I do spend a lot of time undoing these if they're not done well. So it's really making sure that you get the right testing, you know exactly the reputation of the person that you're putting it in. I think mine's pretty good for this one, but she can back me up, hopefully. Now, actually, I can make a sling without mesh too. It's just more complicated. You actually have to harvest a little of your own tissue from your leg or your belly and make a sling out of it. Works pretty well, but it's just a big old recovery. It's a much harder recovery. Like the sling, it's the same day procedure. Usually not too much discomfort for the first few days. There's some activity restrictions, but you're pretty back up and running pretty quickly. The fascial sling is just a much harder recovery. But I still do those for people that need it for severe cases and things like. Or if you just really don't want mesh, then we're happy to do it. It's just a harder procedure. Or there's something called bulking, which I do a lot of. This is like quick recovery, almost zero risk to the procedure. I still do it with little anesthesia because it's not very comfortable. You put a little camera in and injected gel into the urethra so it's stronger. I'm just trying to plug the pipe, basically. So it's not fixing the wiggle of the urethra, but it's still trying to make it so it's stronger. Upside of this, you're back to work in most activities a day or two later. There's really no restrictions. The gel we use now is really advanced. It allows your tissue to heal into it rather than being a permanent material. So it's not something you have to keep getting repeat treatments for. So it sounds great. The downside is it's just not as strong as the sling. So it's better for milder incontinence. I would say if you're okay with the first one not working as well as you want, you still see over 60% of people where it works great, but sometimes you come back and you're like, well, that just didn't work as well, just not as strong. Or when I'm fixing other things, I just need to give like a little zhuzh in the right direction. This is good for women who still want kids. I do that for like, I want to get a little better, but I still want to have kids and have them come out down there. A lot older patients where they're a lot weaker bladders or things like that, or somewhere in between. And there's some older procedures where you use sutures, but they really just don't work that well, so I don't do them very often. And that's incontinence. Am I running over time yet? I have a couple other things to talk about. Any questions on P?
If there's a, I mean, I think inevitably as you get older, there's more of a frequency, like do we need to go more often?
Yep.
But if there's not leakage, is the frequency a problem?
It's only a problem if body.
If it becomes a problem?
Yeah. I have some people like, yeah, I drink a lot of water, I pee 10 times a day, but I don't care. Then I'm like, cool, you do you.
Yeah, that's me.
It's fine. Yeah, there's no overactive bladder is considered as it's frequent urination that's bothersome. So there's nothing wrong with it. It's when you can't, like your life is ruled by it, and it messes things up. There. I pee more often just because I also work at a place with lots of bathrooms, and I drink a lot of water and coffee too. So nothing wrong with that. All right, prolapse. No one wants to know about this condition, but it's really common and very fixable. So again, it's the abnormal descent of the uterus or the other structures outside where they're supposed to be. And again, you're born with a natural opening. That's where babies come from, where you pee from, and where you have sex.
So it's like this one.
yeah.
And then
Yeah. And then damage to these muscles, usually during childbirth. Injury means that the shelf that holds everything in gets weak, and then pressure over time equals a hernia. Just like people have hernias in their belly button or through their diaphragm, it's the same thing.
Is it a symptom thing, or is it like, how do people know that?
Yeah, that's a good question. If you don't have any symptoms, it doesn't matter. Everyone, actually, anyone who's had kids has a little bit, because it's just not going to be as like perfect as someone who hasn't. It only matters. This is purely a quality of life condition. So if it sticks out, so basically, people come saying something's falling out. Like there's like a ball or a bulge, anywhere from this big to like a football. Depending on how things can get. Usually that one you have to wait a while to get to that one, so it doesn't happen overnight. Or hard to empty your bladder, or hard to empty the rectum, irritating, uncomfortable. That's kind of what we're looking at. But it's just, it's just a herniation, but it has a stigma because it's from the pelvis rather than sticking out your belly button. Really common. So we think about 11.5%, we think it's older now, so almost 1 in 6 women will need to have some sort of treatment for their rectum. There's 10 people here. So here's kind of the normal support of the pelvis. It's hard to see. This is a cross section of where she is. So in the front, you have your pubic bone here. Is your butt. And in the front is the bladder and the urethra where you pee from. And if this tube is weak, that's where that stress incontinence comes from. Here's the uterus if you still have one, and the vagina, and the rectum, and the anus. And they should all be kind of held up here by these little suspenders and the pelvic structures. But if those are damaged, am I right? Put the labels there, look at me. I have this conversation like 50 times a week, so it's one of those,
Oh, I forgot
I get ahead of myself. Yeah, I put that in. So you can have any of the parts can come down, and everyone's different. Am I okay on time?
You have if you're good, we're good.
I'm good.
What?
Are you
Okay.
guys good? Okay.
Yeah, I think we're through the bulk of it.
Yeah.
But, uterus can come down. If you had a hysterectomy, the top of the vagina where the uterus was can come down. The front wall where the bladder is, the back wall where the rectum is, alone or all together. Usually it's all together. Risk factors, again, the more kids, if you had like forceps or a vacuum birth, it's just a bit more force down below. Age, menopause, chronic constipation, chronic cough, anything where you're putting a lot of a lot of pressure, really heavy lifting. So sometimes in CrossFit athletes and things like that, we do see a bit more, but there's ways to do it better where you have better support. But people have done some interesting studies about that. And familial, it runs in families. So the more first and second degree relatives you have, it just has to do with your connective tissue. And actual connective tissue disorders, the most common is called Ehlers-Danlos. Those are the people that were like double jointed when they were young, like really
they do the
flexible.
potty training.
It means everything's stretchy, and actually have a lot of women. We're actually doing a study now to really screen for Ehlers-Danlos in young women who have this. So I see someone in their 30s with prolapse, I'm like, ooh, what's going on? Much more less common than someone in their 70s. And then the symptoms we talked about already, things falling out. Sometimes people have to push on it to pee or to poop. It's called splinting. It just means that you actually have to get that pocket to empty so that you can empty. And it's safe to do if you need to. And while it's an uncomfortable condition, it's not usually painful. It's uncomfortable. But when I see someone come in with like, I have severe pelvic pain, pain with sex, all these things, I'm always looking for something else. So muscle problems, back problems, endometriosis, gut problems. This just tends to be annoying more than anything else. We do these exams. Again, if you come to the office, it is a pelvic exam. We tend to be the gentlest of the pelvic exam people because we want you to be comfortable. We are sitting there and straining and pushing and seeing what comes down. We actually take measurements to see what it is, and so you don't have to do too many exams. You do one and you call it, so we know what's going on. But we see what's sticking out. So here's someone's uterus coming out, front wall, and things that we see. Stage 0 means perfect, like healthy 15-year-old. And stage 4 is as far as you can get out, which is the length of the vagina. So I've seen some this big, but you usually have to, again, wait a long time for that to happen. And again, since it's not dangerous or emergent, you don't have to treat it if it doesn't bother you. Some people have it there and it doesn't bother them, and cool, I don't really care. You can live with that if you need to. Most people it does bother them, and that's what I spend most of my time treating. And there are conservative treatments, non-surgical and surgical treatments. Conversely, if you go to the primary care or something, you do a pelvic exam and say, oh, I think you have prolapse, but you don't feel anything, it doesn't matter. Because I get a lot of referrals like that, and then I do an exam, and I'm like, well, if it doesn't bother you, then there's nothing to do. So we talked physical therapy is going to help. Now this is where, this is my part.
Yeah.
PT works for so many things. Once prolapse has gotten past a certain point, it really doesn't.
Yeah.
Sorry, some people think
No,
it really
it's
just
true.
don't do like 100 sessions. It's just not going to go back in.
Yeah.
But when you're early, it can really prevent it from getting worse and kind of stabilize your symptoms. But yeah, if it's this far out, it's not a turtle, unfortunately. It doesn't just go back. Vaginal estrogen doesn't treat prolapse, but it makes the tissue less irritated. So if it makes it less irritated, great. Again, pessaries, there's all these shapes and sizes of things that we fit specifically to you. And it sits inside the vagina and holds things up. So while it makes you so you can function better, but it doesn't fix it, right? So you have to maintain it yourself by taking it out, cleaning it, putting it back in. Or a lot of women who aren't comfortable with that see us in the office, where we do that every few months to see them, to make sure that things are held up okay and there's no problems that are coming from that. But really, if you want it fixed, it's a surgical problem because it's a hernia, it's a structural issue. And this is where my thinking comes in. There are 15 different ways to combine procedures for each person. We tailor that to each person. And again, if you see a doctor for this, ask, do you offer all the types of treatments out there? Do you customize that to some people? Because some doctors only have one or another. You need to make sure you're really balancing. So I do use mesh for some of these. You can lift things up with mesh, which is really good for sexual function and durability. You can do it without mesh. You can do it with keeping a uterus or with a hysterectomy. You can do it for maximizing sexual function, or if someone's not sexually active, taking advantage of that and actually making the most durable repairs. So there's so many ways to fix this, but all of them, home the same day from surgery, minimal to no narcotic use afterwards, up and walking and moving after surgery, and just 6 weeks of some restrictions to let things heal. But it's not big incision, like bone pain kind of, it's surgery. It's not everyone's favorite thing, but they're actually really minimally invasive techniques that we use for it. So then when to seek care, just when you're bothered by it, just don't wait, ask for a referral. There are some urologists that treat these too. You just have to make sure the urologists that focus on this. They tend to be a bit more focused in male urology than female, but it depends on the group. And here's my team. So we formed the Advanced Pelvic Surgery arm at Renown Women's Health, which again is a joint group with UNR. I'm technically employed through UNR, but we're part of this group together. There's me and Dr. Dow, who is out for the next 3 months with her baby, but she'll be coming back, I hope, in 3 months to see patients as well. If you're more comfortable with a female doctor, we treat things extremely similarly, same philosophy. Again, patient-tailored, evidence-based, trying to get your function better without the minimal chance of consequences. That's the thing, you don't want to fix something and cause a new problem, right? So you're trying to find that balance. And then, less for this group, but Dr. Novoa is my other partner. She is a minimally invasive surgeon, so she specializes in endometriosis and fibroids. The easiest recovery, the most skilled surgery, and she's specifically trained in that. So that's more younger patients, but that's our group there. And our offices, we have one right in South Meadows and in the main Renown
It's called
facility.
advanced pelvic surgery.
Yeah, you just look up Renown Women's Health, though, it'll be under there. Yeah. And that's all I've got. And then you want to add a little more about you.
Yeah. So, we already kind of talked a little bit about what pelvic floor physical therapy was, and some of you have already heard about it. But when we do the evaluation, we're really assessing the musculoskeletal and neuromuscular pelvic floor system. Okay, so we're looking at your back, your hips, and how they're all functioning together, your core muscles. We talked a little bit about breathing mechanics. But with our practice specifically, you get that one-on-one care with your pelvic floor physical therapist for a full hour. It's very rare that you get a full hour with a provider. And so, when we're looking at as far as like different treatments that we do manual therapy, so that can be in the hips, back. We make sure that those tissues are moving well. We do internal manual therapy to the pelvic floor muscles So, other things that we look at when we're looking at the neuromuscular system, we look at one, coordination of the muscles. We look at your balance. If you're, trying to get back into physical activity, but you're losing your balance, it's okay, let's look at the whole chain from your foot all the way down or up to the hips. Sometimes stress can impact us, right? If we're not sleeping well due to hot flashes, brain fog, all of those types of symptoms that come with menopause, we teach you stress management as well. And so then when it comes to, we talk about some behavioral modifications. So with a lot of my patients, I have them do actual voiding logs because we're having this urinary urgency or frequency. It's like you're driving home and all of a sudden your bladder hooks up to the Wi-Fi of your house and I gotta go, right? And so we teach you urge strategy techniques on how to improve that so that you're not having leaks when you're heading home. We look at different toilet strategies. Dr. Faulk mentioned splinting, so that's where you actually have to press at the perineum or insert a finger into the vaginal canal to push either back onto the rectum to facilitate stool to move out, or pressing forward on the bladder to help you completely empty. So we talk about different strategies for that, as well as what are you doing in your day-to-day activities? When are you actually having those symptoms of leakage? Is it when you are jumping rope? Is it when you're arriving home? Do you feel that pressure or heaviness with any of those symptoms as well? And of course, we're going to give you, some exercises based off of whatever condition. So we're going to ask very similar questions to whatever your medical provider would ask. Gynecological history, surgical history, how many babies have you had, or did they come out to be a C-section or a vaginal birth? If it was a vaginal birth, did you have any tears? Did they use forceps? Things along those lines. And then we're looking at, all of what's happening here. So you've heard this internal assessment multiple times, and so everyone always wants to know, well, what does that mean? So generally, I do an external assessment. I look, okay, what are the muscles doing? So I have you, one, contract the muscles to see, do they pull up and in? Are we using any other muscles to facilitate that? More importantly, I'm looking at though, do they release? And if so, when you go to bear down like you're having a bowel movement, do the muscles come down with it, or are they pulling up and in? Because if you've had a history of constipation, those muscles are pulling up and in, then it's like you're trying to push stool out a closed door. It just doesn't work. And so we want to make sure we have that springiness and flexibility of those tissues that sometimes are a little limited when we go through menopause. So that's where the topical estrogen can be super helpful with that. Can also, with the topical estrogen, can make internal treatment more comfortable as well. Because if we're having vaginal dryness, things feel kind of sandpapery. We want to make sure that, otherwise, how am I supposed to get a muscle to release if you're having that sensation, right? So it can be a vaginal assessment. It can also be a rectal assessment, especially if you are having, maybe even constipation, bowel incontinence, things along those lines that can also be contributing factors. But again, just looking overall, how are those muscles functioning? One of my favorite things to do with my gals who are experiencing prolapse, that it is, okay, I'm standing, been walking a long period of time, or if I'm squatting, lifting, well, let's see what happens when you're doing those motions. So doing an actual standing assessment during the internal component of it and seeing, okay, what happens if you exhale when you do this? Okay, what happens if you inhale? Are you getting your core muscles to fire on at the same time? Because I've taken people where I have them laying on their back for the internal part, and I'm like, okay, things are functioning the way that they should be. We get you standing, and it's like day and night, completely different, because gravity, unfortunately, has a toll on us. So, as far as what it kind of looks like, because sometimes you're like, okay, I hear physical therapy. Am I going to be out in a gym with a bunch of other people? Are we all wearing gowns? What's happening? So when you come into us, we do have individual treatment rooms where, the first few minutes generally we're talking about, okay, how have your symptoms changed? What's bothering you today? Okay, and so then, sometimes we're doing internal treatment one day. Sometimes it's, okay, you get to keep your pants on today. So we're gonna go out into the gym, we'll maybe do some activity, see what's really, you know, how you're moving overall. But you get that one-on-one care with your PT in an individual space. So
Police
we have
press, we
some
only
parts.
refer to groups that do that. So I'm
Yeah.
really thinking about vetting these groups. I've worked with, I'm biased, I've worked with them the longest since I've come here. And I truly think they're one of the top groups. And the 4 or 5 of them.
There's 4 of us.
Four
yeah.
that are all working together. There's also other good ones with different insurance coverage, but really that one-on-one long time is really important for this kind of therapy, so it's important to focus on.
Absolutely. So, and all 4 of us are board certified, so, and we all do internal treatment. So there are some out there that maybe aren't that, and they're saying that they're doing pelvic floor physical therapy, but if you're not getting an internal assessment, how are we supposed to know what's actually happening with those muscles? So,
I have mesh from hernia, the inguinal,
Yeah.
that caused a lot of adhesions. And so that actually was really helpful.
Right, yeah.
That was what solved it.
yeah, we look at that scar tissue. If you've had any abdominal surgeries, if you have a history of diastasis recti, if you're familiar with that. And so after having multiple pregnancies, you know, everyone is going to experience some stretch to the abdominal wall, right? And so if you've had multiple pregnancies, sometimes it's harder to get those core muscles to turn on to manage that intra-abdominal pressure, and then next thing you know, you're having a leak when you cough or sneeze. And so we gotta work at the whole system.
So I hope today's been helpful to talk about these things. You now are all closer together. We discussed
Yes.
all together. It's just all about awareness. I just have seen too many women that said, I wish I knew about this 10, 15 years ago, and that's sad to have to go through those things. But again, hopefully none of you do need to seek the care of us, which is the best thing. And that's why prevention is her job.
So yeah, so I've had people even where they're coming into me and they're like, okay, well I have this prolapse, and it's, you know, they've seen a provider and they're ultimately gonna get surgery because it's a structural issue where the ligaments just don't have that hold to it, where it's okay, well you do rehab for your total knee surgery, right? Why don't we do rehab for any sort of gynecological surgery? So it's, let's get the muscles moving the way that they should be, then you have surgery. If you need to come back, you know, we just want to make sure that things are still doing what they need to do. We can set you up for success. So,
Thank you. Thanks, you guys. Do you guys have any questions before? No? We're good? Thank you so much for being here today, you guys. You guys were awesome.
Meet you all.
I'm gonna leave.
We'll see you running.